Hi, this is Brian Kim. I want to share with you this case of a patient who suddenly moved while I was making my paracentesis incision, and it caused basically a corneal laceration. So I want to go over how this happened and basically, what's your next step once you have this very large corneal laceration, it's a leaky incision, and how are you going to be able to do the cataract surgery? So this is a cotton tip. I'm using it to control the eye and center the eye. And this is a corneal marker, which will hopefully help me center and size the rexus. I'm using the cotton tip to hold the eye here and make my paracentesis incision. You can see how the patient is moving even when I'm trying to make this first incision. But this is when things go wrong. I'm going to try to make my paracentesis on the left side, and the patient suddenly moves. This is the left eye, and I'm trying to make my paracentesis incision with my left hand, and I'm placing my hand on the patient's cheek. And when the patient feels my hand on the cheek, she suddenly activates her cheek muscle, and it basically moves my hand and causes this laceration. So let me show it again one more time in slow speed. As I put my hand on the patient's cheek, you can see the instrument actually moves even before I make my incision. And then I do it again, and then it causes that movement. And so now I have a really big incision. I'm sitting there trying to think, okay, how am I going to make my paracentesis incision? This is going to be the incision for my chopper. And this really can't be an incision that leaks. And so what I decided to do is really rotate the microscope counterclockwise, and I'm moving my chair to the right. And I'm going to have to sit in a more supratemporal location. And so I'm trying to think, how am I going to make my incision? And I realize, there's no way I'm going to be able to make my incision because it's right in line with that corneal laceration. And so the only way to deal with this situation is just to place a suture. By placing a suture, I'm essentially pressing the reset button. By closing the incision, I'm able to make sure that the chamber is going to be formed and stable. But this also means I'm going to have to approach the eye in a completely different angle. And so that's the first issue. You can't lock yourself with the attitude that, you can't move or budge from your normal surgical position if you want to sit, temporally or whatever, and you're used to having your hands in a certain location. You're going to have to be creative, you're going to have to adapt, and you're going to have to do the surgery in a little bit of an awkward position in order to achieve the best result and to provide the safest surgery. Because yes, it's going to be in a different location than you're used to, but at least you're not going to have an incision that's leaky, and which increases your risk for complication. So I made a new paracentesis incision, more temporal. I'm going to have to sit more superior. Again, this is the left eye. So I made the paracentesis more temporal. I'm also sitting more superiorly, and I'm able to go ahead and continue the surgery. So that's intracameral lidocaine, and then intracameral epinephrine. And this is dispersive viscoelastic to fill the chamber. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, turn the eye towards me with a cannula, and then I enter. I push some more viscoelastic in. And so, I'm really on top of the patient's brow now with my forceps. Again, very different feel, a little bit more awkward, but you should still be able to do the surgery even though it's a little bit less familiar with the movements. So I puncture and I pull down. I grab the right side of the tear, start to create a flap, going around circumferentially, trying to stay within the confines of the corneal mark that I made before. Go ahead and finish the rexus, and then burp some viscoelastic out. And this is a capsular fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally, point the tip down, get a nice wave, point the tip back up, decompress on the left side, point the tip down on the right, which hooks the peripheral lens and it begins to spin. So you can see I'm really actually pretty superior in my location of my main incision here. I'm irrigating the surface of the cornea, adjusting my sleeve length, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. I'm going through my new paracentesis incision, removing the surface epinuclear material, placing the chopper underneath the rexus edge contra-incisionally. The phaco-tip is rotated vertically, sub-incisionally, tilting it. Both instruments are brought together, crushing the lens in half. That's double chop, placing the chopper around the right heminucleus, pulling it centrally toward the phaco-tip, and that is cross chop. Lifting that first quadrant up with a little bit of vacuum, and then using crushing forces to make the pieces smaller, and then emulsify the lens piece. Using the chopper to hook the piece up, and then emulsifying that lens piece. Placing the chopper around the second quadrant, pulling it towards the phaco-tip, crushing the lens between the instruments. I'm trying to use a little bit of vacuum to grab that piece. It's not really wanting to come up. I place the chopper around the lens piece and then carefully pulling it up out of the bag. So that's the beauty of using the chopper to pull the pieces up. Sometimes the vacuum doesn't allow, even though you're using a lot of vacuum, the lens piece doesn't want to come up. I turn the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally, crushing it against the phaco-tip, and dividing the lens piece. Crushing and dividing that third quadrant into smaller pieces and emulsifying the lens pieces, placing the chopper around the fourth quadrant, pulling it centrally toward the phaco-tip, crushing it, and then emulsifying the smaller pieces there. Using some vacuum to grab the anterior aspect of the epinucleus, which comes up. It's a little bit of a thick epinucleus. I'm making sure that the chopper is deep to protect the posterior capsule, lifting the epinucleus up, grabbing it with some vacuum, and then the epinucleus begins to prolapse up. Keeping that chopper deep to protect the posterior capsule. Getting those small pieces that are stuck with the viscoelastic. So I take the chopper out, push BSS in, take the phaco-tip out, and I go in with the INA handpiece. I always start sub-incisionally, removing the cortical material. Try to remove it from anterior to posterior. Peeling it from anterior to posterior provides a more clean removal of the cortical material. Switch to polish mode, polishing under the rexus edge. And polish the posterior capsule surface as well in the subincisional area here. Yep, there's a little bit of cortical material right there. So I loosened it up using the INA tip, and then I'm using a BSS cannula to go underneath the subincisional capsule fornix, and then I'm going to pulse, and it causes that cortical material to get loose, and then I go after it with the INA handpiece. You have to have good bimanual coordination to do this. If you don't, I wouldn't recommend flushing the capsular fornix. So go ahead and push cohesive viscoelastic to fill the bag, and then we're going to polish under the rexus edge, first on the left side. And then on the right side. So I'm injecting the single piece acrylic intraocular lens into the capsular bag. The leading edge goes into the bag. While the lens unfolds, I go in with the INA tip, activate irrigation once I'm in, making sure both haptics are disengaged from the optic, going underneath the lens, tilting it and rotating it 90 degrees clockwise, removing all the viscoelastic from within the bag. And by tilting it, you're not causing any zonular stress with that maneuver. Polishing underneath the rectus edge again. And then switching to viscoelastic mode and removing the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. So again, this is a patient who has some cognitive deficits, was a little bit confused, and was responding to stimulation. So otherwise, you can see she's pretty compliant. But when I had my hand on her cheek, that stimulation caused her to activate her cheek muscle and try to knock my hand off her cheek. As I'm trying to make my paracentesis incision, suddenly that movement of her cheek causes my hand to move uncontrollably, and it made a large cut in the cornea. It obviously wasn't quite limbal, it went more anterior, and clearly not a controlled incision. So if I tried to use the paracentesis for my cataract surgery, I would have a lot of leaking from that paracentesis incision, unstable chamber, and as a result, higher risk for post-occlusion surge, higher risk for a posterior capsule coming up and hitting the phaco-tip. And it's not really a good way to do cataract surgery when you're trying to push a square peg in a round hole. If you're trying to force the issue and you try to just barrel through and continue to do the surgery, even in the context of less than ideal incisions, that is really the bad way to do cataract surgery. You have to adapt, go ahead and close the incision, rotate, and even though it's an awkward position to be doing surgery from superiorly, it's at least going to have better chamber stability. You'll have to be mindful of adjusting your technique slightly, but overall, you can see this case essentially became routine. Rather than struggling and trying to deal with a bad incision, you basically close up, press the reset button, and create a new incision. And as a result, you're able to have a safe and excellent outcome without struggling with this potentially challenging case. So I hope this was helpful to you, and I thank you for your attention.